Okay, I see people starting to join the webinar. Thank you to those of you who are here today. We're going to get started in just a minute. We're going to let some more people join as the participant number ticks higher. We will get going probably about 1:02, 1:03 p.m. Eastern. Okay, I think we'll get started here. So, hello everyone. I'm Justin Vinieri, Director of Communications at Capital RX, and it's my pleasure to welcome you and thank you for joining us for today's webinar, 5 Ways to Improve Your PBM Procurement Process in 2024 with Bridget Malvina. So we've been doing a lot of work and generally putting a lot of effort into creating content that helps explain the issues we've seen our partners and clients deal with over the years, especially in and around procurement or the request for proposal process. So, it's a complicated process as it relates to pharmacy benefits. And this webinar is the latest iteration in that initiative, as we think everyone should know what they're paying for. Um, you're all definitely not here to hear me talk, so let me turn it over to Bridget. Bridget joined our commercial team in the fourth quarter last year from one of our clients, Erickson Senior Living, where she oversaw the pharmacy program for their long-term care business and their health plan. And she drove tremendous savings there. So Bridget, over to you, and we'll go through the presentation we prepared. The slides will be available. And one other housekeeping item, questions, if you enter them in the Q&A, we'll make sure we leave time to get to them at the end. And if there's anything we can't answer, we'll of course follow up on that. So Bridget, over to you.
Thank you, Justin, and thanks everybody for joining today. It is my pleasure to be here to talk to you about PBM procurement, which is not a topic that there's a lot of information out in the market about. So excited about this hour. As Justin mentioned, I was a fiduciary at my last job, and which meant I had financial responsibility for the overall management of the pharmacy benefit. And as a result of that, led that team at Erickson Senior Living towards Capital RX, and we built a really wonderful relationship. And now I am here to extend that knowledge and that information to a much larger population. So really grateful for that. I have been in the pharmacy industry for over 30 years, mostly in operations and finance, and look forward to talking to you about how some of that experience has led me to this place. Before we start, as Justin mentioned, I'm going to leave plenty of time at the end for questions. Please feel free to add those to the chat as we go. And here we go. So today we will talk about some winning strategies for PBM procurement. I'll give you a 5-question PBM gut check that I developed towards the end there, and then we'll open it up for Q&A. And I'll just kick off now by asking a question that I think everybody wonders is, does my PBM make more money when I spend more? And the answer is pretty simple. If they're conflicted, meaning they own dispensing assets, they are retaining pharma revenue, and they're managing multiple MAC lists at retail, they probably are making a little bit more money when you spend more money. And so that's something to look at. Do you want a PBM who's making more when you spend more and you're allowing them to control your destiny? And we'll figure that out together over the course of the next hour. So what's the first thing that we can do to ensure we're getting an optimal PBM deal? First is to interview pharmacy benefits managers with aligned fee-based models and transparent pricing. And what does that mean? Alignment means that the goals of the PBM are aligned with the goals and initiatives of your organization, not pushing their own agenda, aligning with your agenda as an employer. And so what's fee-based? Fee-based is you pay the price for the actual service that's being performed, and there is no money that comes from other farmer revenue resources being retained or kept by your PBM. And then transparent pricing, really simple. It's a pricing structure or a cost basis that is easy to locate, publicly available, and accessible. So you don't have to pay tens of thousands of dollars to access data and access information through Medispan or one of those other entities. So we'll expand on that a little bit. And this slide talks about the different buckets of money that go into and flow through traditional PBM models. And so there are admin fees and clinical program fees, and those can be assessed on a per claim or per member per month basis. Those are really unconflicted relationships. But when you get into when pharmacies own retail, when PBMs, own retail pharmacies or mail-in specialty pharmacies or a GPO or a rebate aggregator, that there's a lot of conflict in the pricing models there. And that's where it becomes opaque, and it's not easy for us as PBM procurement people to find a clear path towards what the price we're paying for drugs is. So we know that AWP is a very popular cost basis. We like to say that AWP ain't what's paid. WAC is typically what's used in the industry for branded medications, and that can get really muddy as well, because it's just one price, right? There's no average when there's one manufacturer on a brand. And then you have NADAC or NADAC, depending on how you pronounce it, where you came from, which is National Average Drug Acquisition Cost, which isn't perfect. It covers about 99% of all drugs, but is the closest thing that you can get to a cost plus cost basis in a pharmacy contract. So it's a good idea to talk to your PBM about NADAC and see if they're willing to move their cost basis in that direction. So moving on to the next slide here, we'll talk a little bit about what NADAC is. NADAC is Medicaid acquisition cost. The NADAC index is publicly available. It is on Medicaid.gov. It is updated every 2 weeks, and you can go in and look up an NDC and find the national average acquisition cost for that drug. It correlates to actual costs. It's the same. It behaves the same way for branded generics. It is not a cost basis that can be manipulated, so you can't bury any spread into that contract. It's free. You can access it as many times as you want. You don't have to pay to download it, and it's managed by an objective government entity, which really matters. And so, what other things can you be doing? You can look for a PBM that'll offer you an all-in per member per month fee, meaning that all fees, all the costs of the drugs, everything that goes into the management of your plan gets charged by one fee, and that fee is a number that the PBM agrees to hold themselves accountable to and is willing to put their profit at risk to make sure that you get there. Replace AWP and MAC lists and WAC with a more rational benchmark like NADAC, something that is transparent and trackable. And identify PBM partners that don't own conflicted assets. They don't own pharmacies, they don't own specialty, they don't own mail, because if you've ever sat and wondered, as I have, where all that money goes and thought that it was opaque and a mystery, you're right, it is, and it's that way for a reason. So moving on to the next one, and this is a really interesting one. Let's focus on drug mix. Drug mix is really where the magic happens. And in April of 2018, when I sat down with the PBM in my last role, after renegotiating a new contract that appeared to have price concessions in it, I was shocked by the fact that the drug spend was a lot higher than it was for the same quarter in the prior year. I was expecting price concessions, and so you expect that number to go down. And the response that I got was, well, you have more specialty and high cost brand usage than you had the same period last year. And that's all well and good. But when I dug in, that was not because I had that the organization saw a large increase in chronic disease, or increase in age, or increase in utilization in any one particular category. It had to do with the PBM at the time controlling the formulary and not allowing for overlay exclusions. And so, yes, my brand specialty went up because I was not in control of what drugs were on the formulary. And I was not in control of step therapy programs and prior authorization programs and quantity limits. And so when we think about price concessions, you want to stay in this unit cost box, right? But this drug mix is really what goes into determining what you're going to pay for the drug. And when your pharmacy benefits manager tightly controls the formulary, and their pharmacy and therapeutics committee selects drugs that are clinically appropriate but have higher rebate potential, then the potential for you to spend more money exists and actually becomes a higher risk. So now we'll move a little bit into a demonstration of what a rebate chasing agreement looks like versus an aligned PBM agreement. And so in an aligned PBM arrangement, you may see smaller dollar for dollar rebates, but what you'll see is a more rigorous prior authorization process, because there's no conflict, because there's no ability to make more money when a plan spends more money. So this demonstrates the difference between this specialty drug with a high rebate, same specialty drug, slightly lower rebate. Obviously, same applies here for a non-specialty, but when you apply a 90%, which is the average PA approval rate for most of the larger PBMs, versus a 67%, it decreases your spend significantly over time, even if your rebates are lower. And we're going to get into this a little bit later, but the beauty of rebates is that they can bring down your total cost at the end of the year. But I always say, if you never paid for the drug, the rebate doesn't matter. So push back against that argument. You have higher brand or specialty drug use when your spend goes up quarter over quarter. Ask about drug mix, and not just what about my drug mix. What are you, PBM experts, doing about my drug mix? How are you helping me reduce spend with drug mix? And then seek assurances that your PBM is going to implement measures that align with your objectives. Every year, most large organizations set goals for the organization around people, process, and profit. And your PBM should understand what those goals are and should align directly with those goals so that you can meet those goals, and that are supporting cost savings and member engagement, and also member satisfaction. And look for a PBM that's willing to put their profit at risk. They're putting their money where their mouth is. They're holding themselves accountable. That's really, really important today, especially as we try to move towards a more transparent, value-based care health system. So next, I'm going to recommend that we leverage utilization management tools for specialty medication. And what tools do you ask? Prior authorization rates are a big piece of this. Plan sponsor controlled formulary and plan designs are also a really, really great place to start. And so your PBM will typically have a class of specialty medications that they've selected that are on formulary, and you don't really have a lot of room to budge there. You want to be able to say, we prefer, and especially in today's age, you want to be able to say something along the lines of, we would prefer as a plan to adopt a stronger biosimilar strategy as more and more biosimilars come into the market. And we've seen a lot of success with the biosimilar Semglee because Lantus was a high cost brand, but it wasn't an extremely high cost brand. And that was an easier transition because the rebates there did not really impact our ability to move the needle on that drug. But as Humira biosimilars are coming out and Humira rebates have stayed high, you still see a lot of formularies where Humira is the preferred drug for anti-inflammatory. And that really does create a situation where you get a lower adoption for biosimilars. So specialty drugs are overtaking traditional drugs. We know that this is true. The average plan that we see coming in, about 2% of all claims account for 50 to 54% of spend. And in 2023, 80% of the drugs that were approved by the FDA were specialty. So this is not a problem that we're going to see go away. But there are some things coming that could help. And one of those is specialty generics. And also monitoring the specialty channel spend by your PBM. So if you're looking at your specialty channel spend and you see that there were a ton of fills for drugs that are definitively non-specialty, aspirin, Lipitor, those types of things, you want to address that and you want to go in and look and audit that and make sure that you're actually paying your generic rate and not your specialty rate, because a lot of times those rates will get charged by channel. When utilization is low, specialty is still a leading cost driver for plan sponsors, and that increase is not expected to abate anytime soon. So, ensure a thorough evaluation of prior authorization by PBMs. You want clinical vetting, you want diagnosis criteria, you want lab work reviewed, and you want at times medical records to be reviewed. You want to make sure that people are getting the appropriate drug for their diagnosis and that you're not paying for medications that are not going to work or are not clinically approved for those diagnoses. And then inquire about pricing strategies for non-specialty medications. You want to make sure that you are looking at that, because I can tell you in experience, based on my experience, that I have seen cheap generic drugs that should be coming from retail. They're convenience. They're being dispensed through specialty for convenience, and they're being billed at a specialty rate. And that's really inappropriate, and you should really be monitoring that. Okay, moving on to, I'm moving fast because I want to leave time for questions. Moving on to controlling over-dispensing. And this is a really big problem because a lot of pharmacies and PBMs alike are pushing auto refill programs. They're doing that under the guise of this is more convenient for plans and for members. But really, auto refill equals auto profit. Okay. And what we want to do is be really mindful that if your PBM is promoting or pushing an auto refill strategy, that can really result in over dispensing. If pharmacies are auto enrolling members in auto refill programs, it may not be a bad idea to educate your workforce to only sign up for that if they think they have an issue with that. Auto refill originally was designed to help people who have adherence issues, but adherence is a really tricky thing, because adherence, when it comes to refilling medications, is only tracking whether or not they're refilling their medications. It does not track whether or not they're actually taking their medications. So be careful of that. And also, I would be mindful of and careful of and really wary of any PBMs that are encouraging dispensing of extended supply of specialty. You want specialty, especially new specialty drugs, to be dispensed for a shorter day supply. And then, as you know, members can tolerate those things, obviously, then they can get a longer day supply. But I recommend, based on experience, a maximum of 30 days for specialty medications. That's a high change category, and you don't want to end up with a lot of oversupply. The other thing here is refill thresholds, and I'm going to talk about that a little bit before we move on. I recommend turn auto refill off altogether. Turn that off at the plan level. And if you need to have it for appropriate medications, obviously you can select those and have it turned on for certain appropriate medications. But be really careful of this 75% refill threshold, because it's a really simple math problem. If you're on a maintenance medication, and we're going to pick on Lipitor as an example, because it seems like a lot of people are on that drug. If you're on Lipitor once a day, you get a 90-day supply first fill. If you get a 75% refill threshold at day 67 and a half, you can get a refill. That's 22 and a half days early. If you do that 4 times in a year, you have almost a full 90-day supply by the end of the year. And that doesn't mean people, if auto refill is turned on, you're going to continue to accumulate additional supply. But if you slide that 75% refill threshold over to 90, you still have 9 days left at the end of the month to get your medication filled, or at the end of the quarter to get your medication filled, which is plenty of time to submit a refill, get it delivered, or go to the pharmacy and pick it up. And at the end of the year, you only end up with about a month supply of extra medication, which in my mind is enough for, say, a vacation fill, or in case you got sick and you couldn't make it to the pharmacy in time, a 30-day supply is more appropriate. You don't run the risk of medications expiring. You don't run the risk of having to dump these things into our wastewater systems. And so there's a lot of definitive advantages to having a shorter auto refill trigger. And a lot of PBMs might argue that you need to have a longer or a shorter refill threshold, or a longer refill threshold for mail order. And maybe that's true, but nothing lower than 85%, because the US mail and those large mail order pharmacies operate so efficiently that you should have no issue getting mail order medications to patients with an 85% refill threshold. Okay, we will move on here. So here's a big one. Number 5, control or customize your formulary. So what is a formulary? It's just a list of covered and excluded drugs, right? It's a list of all the things that your members or members that are included in a plan can access as a part of their benefit. And you want to make sure that that list is comprehensive enough so that their benefit feels beneficial. But you also want to make sure that that is promoting the most safe and effective medications. And let's face it, not all of the medications that the FDA approves are approved because of their efficacy. They're only approved because of their safety, because they're believed to be safe for use. And then the clinical decision is left up to the physician and the pharmacist to determine whether that medication is appropriate. We really do need to move back to that type of system instead of this formulary-driven system. However, a formulary is a great measurement for how to control your costs. And so you can have a certain number of, you can decide to only go with 2 branded drugs to treat a specific condition and make sure that those drugs are clinically appropriate. You can prefer generics on your formulary by sliding that refill over to $0 for a lot of those things. And you can also implement overlays and exclusions, if allowed by your PBM, to limit the dispensing of low value, high cost medications. And that can save the plan and your members money. You want to look at, there was a drug out a while ago, and it's still out there, obviously, but Prozac fluoxetine capsules were really inexpensive, but fluoxetine tablets were very expensive. And what you saw was a lot of plans move those tablets off formulary and prefer the capsules for cost savings. And that's the type of action you can take here. You can look at combination generic products, or even combination brand products. And there were two out there a couple of years ago that were literally combinations of two over-the-counter products that you could buy a year's supply of for $50, but 1 month was costing plans $2,500. And so you want to make sure that you're identifying those and talking to your PBM about restricting the spend of those drugs on your formulary. So I've already hit on some of these things, but you also want to make sure that you're having consistent reviews with a clinical person, looking at your top 25 or top 50 drug spend. And I recommend looking at it two ways, by cost and by use, and then taking that information back and saying, are these things effective? Are they working? And is there something better that we can be doing so that there is adequate access, but not access to things that are going to cost the plan and cost patients money, but have no intrinsic clinical or appropriate use value. And now the bonus thought, my most favorite and everybody else's least favorite thing to hear. And that is, let's break our addiction to rebates. There are some legislative things coming down, the Inflation Reduction Act. A lot of pharma companies are starting to sunset their copay assistance programs. There is evidence that rebate dollars are going to start to erode. And so ultimately, we're all going to be forced to break our addiction to rebates because they're going to dissolve into the ether at some point. But I think it's really important to understand that if you never pay for a drug, a rebate doesn't matter. And I'll never forget banging my fist on the table with a former PBM that I was working with, because I had spoke on behalf of the team that I was working with. We do not want to pay for these two drugs. And the message that came back was, we're sorry, they're going to stay on the formulary. You cannot exclude them. And the rationale is because they do have clinical value, which is debatable, and the rebate is so high that the cost is negligible. And again, I can understand why that thought process might exist, but I fundamentally disagree that there's no reason we should spend any dollars on something that has no effect, or that can be procured much cheaper through a different channel. So what do you want to look for? You want to look for manufacturer revenue. You want to dig into the details. So what you want is a contract where 100% of your rebates are getting passed back through to the plan. And rebates are not just what's negotiated in your contract. In your contract, you probably have something along the lines of, for branded drugs, you can have $250 per 30-day supply and $600 per 90-day supply. And for specialty, you can have $1,500 for 30 days and $4,000 for 90. And I'm throwing wild numbers out there, so please forgive me. I'm literally just throwing numbers out. The reality is that is your guarantee, and that is what you're going to get. But that doesn't mean that encompasses all of the manufacturer revenue streams, because when PBMs negotiate with pharma through their rebate aggregators, there are other rebate revenue and manufacturer revenue that are included in there, including performance guarantees and performance bonuses if that drug is placed on the formulary and they reach a certain threshold of prescriptions. Because I'm going to bury the lead here. Pharmacy is a volume business. And so volume matters in these negotiations. You want to make sure that your rebate definitions and your contract include what I just described, all manufacturer revenue streams. You want a report every quarter that tracks back to the NDC 9 level what drugs you got rebates for so that you can go in and do a real true analysis for what you're paying for drugs. Because what you see on your monthly invoice for Ozempic isn't really what you're paying. You're paying that minus the rebate. The challenge is that you're not getting the rebate until 6 months later. So it's really hard to track. So having that NDC 9 level report enables you to track and get full visibility into those economics. And then you want a manufacturer contract that's auditable, not audible, auditable. I can't say that word. So you want to be able to look back at that dynamically and get really good visibility into what you spent, what your rebates were, so you can get your true cost. And then you want to look at your growth, right? And so we don't need to get into that. That's more about supply chain. So you want 100% of all rebate revenue less aggregator fees. And aggregator fees should be in the low single digits. When rebates are paid, get the claims, get the claim level detail. It's going to make a huge difference and help you manage your plan more effectively. And then ensure that you've got a really tight rebate revenue definition in your contract, and that includes any volume or performance guarantees that are coming back to the PBM. Okay, with that, I'm going to really quickly go through my 5-question PBM gut check. And these are just if you're thinking about PBM procurement for 2025 or 2026, maybe the next time you're in a meeting with your PBM partner, you should ask some of these questions. Do you automatically approve prior authorizations because of preferred formulary placement? And what is your PA approval rate? And be wary of the answer that, we don't have people touch it. It's based on an algorithm, and the algorithm decides to auto approve because that algorithm is just tied to, is it on formulary? Yes. Then it likely gets approved. And that can be a slippery slope for plans when it comes to finances. Ask if they'll provide an NDC level detailed report of rebated claims paid to the plan. And if they say no, then maybe follow up and say why, ask why. And then just keep that answer in your back pocket for next time you want to do a PBM procurement. Ask about the refill thresholds. How early can members get their meds refilled? And how much control does the plan sponsor have as a fiduciary to limit waste and protect the safety of members? Because ultimately, at the end of the day, that's what it's about. It's about limiting the amount of excess funds the plan puts out, but limiting waste in a system that's rife with fraud, waste, and abuse, and protecting the safety of the members. We want to know what percentage of a plan's copay assistance dollars that are being retained. Copay assistance is not something that we spoke about today, but copay assistance dollars are very, right now, they're plentiful in the space, especially high cost brand and specialty. And you want to be able to access the full amount of those funds when they're available at the point of sale. It'll help offset the members' copay share, but also advantage the plan and hit the bottom line, which, let's face it, that's what plan sponsors really, we care about our members and we care about our bottom line. And then ask to see the language in the contract that guarantees 100% pass-through of rebate revenue, including biosimilars. Now, be mindful that not all biosimilars have rebates associated with them. However, the ones that do, you should not be penalized as a plan because your PBM isn't passing through biosimilar rebates because it's not in your contract. You want to make sure that if biosimilar rebates are available, you are contracted to get them paid back to you in a timely and in a 100% pass-through fashion. So with that, I'm going to turn it back over to Justin, and we will go into our Q&A.
Thank you, Bridget.
Thank you.
And thank you to the audience. We have actually a couple handfuls of great questions here, so we'll try to get through these. Also, we're going to run a poll, just a quick poll at the end. So if you stick around with us, we'll get through these questions and it'll be probably 20 seconds of your time. We'll appreciate that. So let's start off. I think this is a pretty straightforward one on NADAC. So, hi, do the big chains, Walgreens, CVS, et cetera, also report into NADAC?
No, they're not. NADAC is it's a survey. There's just under 1,000 pharmacies typically report into there. It's mostly like grocery chains and independents. And so it is tracked that way. I can assure you that if the big chains reported into NADAC, then NADAC prices would be a lot lower.
Got it. And I think are some of the bills and some of the legislation moving around has suggests that could number of pharmacies that contribute may increase over time. Is that true?
Yeah, yeah, that is true. And that would be remarkable. It would be even better if all pharmacies in the country were mandated to report in. That would really change the pricing landscape for pharmacy.
Cool, thank you. Next question we have here. There is a significant group of people out there making the argument that no one should be telling doctors what they should or shouldn't be prescribing. I think this relates to the prior authorization comment. This participant says, I don't agree with that, but I'm curious what your argument is to a plan sponsor who might be listening to these folks making that argument.
Well, I would say that, if it's very, very hard for a non-clinician to tell a clinician what should and should not be prescribed for their patient. However, I've worked with a large number of providers, be they nurse practitioners and doctors over the course of my career. And one of the comments that I often hear back is that they don't know what to prescribe. And so having a pharmacy resource, whether it's through the PBM or talking directly to the pharmacist that's at the dispensing pharmacy, have a clinical peer-to-peer conversation between, say, a pharmacist and a doctor. If that's happening, then I think that doctors are very open to hearing the opinions of pharmacists, to hear what's working, to hear what's not working, what they're seeing, because doctors are just like us, right? They're trying really, really hard to provide a service to their patients who are also healthcare consumers. They want to get it right the first time because there's no value in them having to touch those patients multiple times. And so I think that, while we don't want to dictate what drugs doctors are prescribing, we want to create an environment where effective clinical collaboration can occur and that both parties feel satisfied that they got the best possible outcome for the patient.
Got it. And let's see. The next question. Bridget, what do you think the future of specialty carve-outs that go after PAP plans, patient assistance program, and to pay for the drugs are or is?
I think that's a tough one. I think as we, there's patient assistance programs. I think what we're seeing already is those are starting to dissolve. The money is running out. There are a couple of great products and great companies out there that are doing specialty management. I think it's going to be less about PAPs or copay assistance programs as time goes on, and it's going to be more about identifying genetically, using pharmacogenetics to identify which drugs would actually work for patients, especially as these programs start to dissolve and go away. We're already seeing huge shifts in what some of the payers, what the pharma companies are offering in these patient assistance programs. And quite frankly, the lift to access those funds can be significant and costly for both plans and those specialty carve-out providers.
Okay. And then another one came in. Does Capital RX have the capability of capturing copay assistance at the point of sale and reporting that back to a plan?
Yes, Capital RX has a program called Cap RX. And that program is driven obviously by plan design. And what we do here at Capital RX is we will help the plan sponsor identify a copay share. It wouldn't be a copay, a co-insurance, more than that, based on the total available funds for a specific drug. And that does happen at the point of sale. And so you see the application of those dollars right away on your very next invoice. And the member sees it in real time. So I'm going to just throw out a number. If the specialty copay is $100 and the copay assistance covers all of that plus some, then the member will pay zero and the plan will get the benefit of the rest of those dollars. And that does happen in invoicing time, which is real time.
Okay. And then this is an interesting question. I think um, maybe you can answer it from the perspective of your prior seat. There are people and companies that measure the purity of generic drugs that claim that generic drugs do not have the same purity and that there's actually a difference in the generics and brand drugs, also biosimilars. What would you say to that assertion?
I would say that that this is something that's been going on in the pharmacy industry for years, and that there is a faction of people who believe that generic drugs aren't as good because they're not the original brand. The reality is that the United States has got pretty strict rules about manufacturing, and that any generics that are approved and any generic manufacturer that is approved, so the generic drugs have to be AB equivalent, meaning that they have the same recipe, for lack of a better way of putting it, and that the facilities where they're made are inspected regularly by the governing bodies that do those inspections. And so I think that, that's a good argument. I think that it sort of goes back to is the store brand cereal, does it taste as good as the Kellogg's brand? And maybe that's not always true, but that's not the same for drugs because they are so heavily regulated. I think that we can all feel safe and secure that the generic drug manufacturers and the biosimilar drug manufacturers out there are making drugs based on the original recipe and that they are safe for use. And I'll clarify with biosimilars, because a biosimilar isn't really a generic. A biosimilar is a biologically similar drug because specialty drugs are biologically based. Um, and they are not exactly the same, but all of those also go through the same rigorous FDA approval process, and they are subject, the manufacturing plants are subject to the same inspection standards that any other manufacturing plant that manufactures drugs in this country is subjected to. And if drugs are made overseas and sold in the US, then US entities inspect those locations as well.
Thanks for that, Bridget. And yes, we will be providing, again, the slides and a link to the recording after this is wrapped up. And we will have a quick poll at the end. We have a couple more questions here. Thanks for submitting these. So if you receive a quarterly data file that includes NDC, how can you determine which drugs are rebate eligible and the amount of the rebate?
Well, if you get just a utilization file that at an NDC level, you're not going to know that. The drugs that are rebatable are going to be spelled out in your contract. There are rebates applied that are available for drugs across all drug types: generic, biosimilars, brand, and specialty, right? It's just not every generic drug has a rebate, not every brand drug has a rebate, and so on. And so what you would need to do is take that file, that utilization file, and if you have in-house analytics expertise, get that NDC-9 file and have somebody go in and do the data analysis, whether they do, I'm going to throw out a weird Excel term, whether they do a VLOOKUP or some other way to marry up those files so that you know that the NDC-9s are matching. Then you can go in and see, here was Ozempic, this is what we paid, this was the rebate, so here's our total Ozempic cost. Unfortunately, the reporting is always retrospective. So you get a quarter behind on your data, and then you get 2 quarters behind on your rebates. The other thing you can do is, if you have the money and you're interested in doing a deeper dive, is engage the services of an actuary, especially a healthcare or pharmacy actuary who has experience in doing this, and they can help you identify that. But I like contracts where you don't get a rebate guarantee for specialty and a rebate guarantee for brands, or a rebate guarantee by category. I like a contract where you get a rebate guarantee across all of the drugs that you use. And that might not look like a pretty number. You're not going to be in the hundreds or the thousands there, but you get it. It's easier to track across all drugs. And then you get the data at the end of it, and you can see, oh, these are the ones that actually got rebates. It just got applied across all the drugs. So there's multiple ways to do this. And it always helps to have in-house data experts, especially people who are used to looking at NDCs and the other pharmacy or the drug claim file specific pharmacy data fields.
Okay. Of all the suggestions you've thrown out today, what would you say contributed the most savings to your plan when you were employing these strategies, and what was second?
So the most savings came from controlling drug mix. I would say that controlling drug mix attributed to roughly 55% of total savings. In part, that was saying definitively, we will not pay for these drugs and excluding those from the formulary. Implementing a low value, high cost drug list where we completely eliminated dispensing of certain products. And then I'd say that it's sort of like tied for second. The second biggest area of savings came in the 100% pass-through rebates, which generated a 3% year-over-year increase in rebate revenue, even though the dollar amounts weren't as high. So the spend went down because of pricing and drug mix controls. So my rebates went down, but when I compared my rebates to total spend, I saw an increase of 3%. That's huge. And then also the copay assistance dollars actually recouping and getting some visibility into what those were. That attributed in 1 year to roughly $1 million in savings. So and $1 million is not a little bit of money. Even if your plan is spending 50, $1 million off, it can be paradigm shifting.
And correct me if I'm wrong, but if memory serves me, you had about 15,000, 16,000 members, lives?
We had just under 11,000 member lives in our plan.
Okay.
Yeah. And in the first year, implementing all of the savings measures that we talked about today, we cut costs in the plan roughly 25%, just shy of 25%. So if you think about if you're a plan sponsor and you're sitting on this call and you think about what you spent last year and take 25% off of that, and that's appealing, then let us know. We'll have a conversation.
This next question, if you can't answer, we can follow up with a clinical response. How do you deal with the new data that is being found that's showing things like statins and SSRIs are actually not contributing to the health of patients? What types of clinical programs or processes does Capital RX have in place for assertions such as those in terms of the actual efficacy of some of these drugs?
Yeah, that's an interesting question. I'm not a clinician, but I will give this answer. And we can follow up and maybe have one of our clinicians look at this and post a LinkedIn post or something to help you guys out with this. But I feel like, we need to be really responsible with people. A lot there drugs like like statins and SSRIs are so ubiquitous right now, that and oftentimes, based on what the Affordable Care Act states, a lot of patients will see statins. Most statins are covered at zero copay, so they'll see them as free, and so why not take them? There's very little documentation about the high levels of risk that exist for folks that take statins and they don't need them. And then there's equal amounts of data out there that say they're safe for everybody, and everybody who can be on should be on one. If you're over 50, you should definitely be on one. And so I think the challenge is that we've got all of this conflicting data out in the marketplace, and the only true way to bring it all together is for more and more plans to adopt a pharmacogenetics sort of mindset where, you invest the money up front, and it's a sizable investment to have this genetic testing done. But once it's done, and it's done for the rest of your life, because your DNA doesn't change that much over your lifetime. And then we know for sure when a drug gets prescribed, it hits that DNA profile, and then this person is not going to tolerate statins, and so they shouldn't be on a statin at all. Instead, they need to be on something else, or SSRIs aren't going to work for this person. Maybe they need to be on an SNRI or something else. And so that's very broad and vague because, again, not a clinician, but I think pharmacogenetics is how we get there and how we solve this problem. And it's, again, if we're going to get to personalized medicine, if we're going to get to value-based care, then your plans are going to be your in value on your plan is going to be 11,000 or 15,000 or 30,000 people, but your in value on drug management is going to be one, because you're going to manage it at the individual level. And that is the best. I think that is one of the best thing that's going to happen to this country, is when it becomes affordable for more and more plan sponsors to adopt pharmacogenetics and get people enrolled and engaged in those programs.
Okay. Believe it or not, we have a couple more questions here from the audience, so we're going to get through these, and then we'll run that poll toward the end. So, if biosimilars aren't explicitly called out in the rebate contract language, should we assume that PBMs are retaining those rebates by default, or would this exclusion for biosimilars be called out in the language if applicable?
It depends on how old your contract is, right? So if you've got a contract that's been in play for 7 or 8 years, probably not going to be a lot of language in there about biosimilars. I think it's part of your fiduciary responsibility as a plan sponsor to bring this up and make sure it's there. But it is safe to assume that if rebates are available on biosimilars and it's not clearly spelled out in your contract, that the likelihood exists that you are not getting those rebates and someone else is retaining them.
Okay. And then we have an audience member wrote in. I'm just going to read this one off. Our broker is telling us that at our scale, about 1,500 lives, we can't get a competitive pass-through contract. Is that true?
No, that's not true. Now, does it mean that you're going to get the lowest rates in the world? Maybe not, but you can get a competitive pass-through contract if you are a 1,500 member life group and you're interested in talking to a member of our team. We would be happy to walk you through that process, but we have a couple of different products that are specifically designed for smaller groups that would help move away from the traditional model and get you into a better arrangement. And then over time, we could migrate and figure out ways to continue to help save you money. We at Capital RX, we hold ourselves accountable to the things that we sell you. And our sales team stays with our clients throughout the process. And so we would make sure, we would walk you through and make sure that you got the best deal that was available to your size group.
Okay. And I just have one more question, but I think we'll pop the poll up real quick. I'm not trying to hold people hostage. I promise. It's a super quick poll. So we'll pop that up, and then it's actually a related question, so it ties in pretty nicely, I think, to that last response.
Okay. Are we done? We're done with questions, huh?
I got one more question, just one more. And it's a good one. So
Okay, let's hear it.
it's probably enough for a call in and of itself. So we don't have another hour though, unfortunately. Um, so Bridget, what's your recommendation for, or how do you think plan sponsors and administrators can get to a place where they're running an unbiased RFP process?
That's really interesting. And so I don't want to, if there are any brokers and consultants on this call, I am not trying to offend anyone. However, if your current broker has in-house pharmacy expertise, then you should be leveraging that in-house pharmacy expertise and asking them to help you find the most transparent, aligned PBM that they can possibly find. If you don't have a broker that has that in-house pharmacy expertise, then I recommend hiring either an actuary, as I mentioned before, someone that can help you analyze your data and walk your current broker through the best way to negotiate and optimize your PBM deal. Or there are several pharmacy benefits consultant firms out there, and I'm not going to mention any names, but there are some pharmacy benefits consultant firms out there that would be happy to enter into a short engagement contract and run an RFP and help you get the best, most optimal PBM deal. So just explore your options, talk to your current broker. And I recommend, I did this with my broker, and we had a great relationship, I think, as a result of this. And obviously I'm here now, I'm not there, but I had a conversation with him the other day, and they were so grateful for the introduction to this other pharmacy benefits consultant. And so don't think that, you hired them to give you advice, but sometimes they need your help just as much as you need theirs.
Got it. Bridget, thank you so much. It was amazing. If anybody has follow-up questions, reach out to either the marketing team at CapRx or um, follow up with your contact at CapRx if you already have one on the account management side. And we'll send around the slide deck and the link to the replay.